Welcome back. So we've talked about some of the things that got me to the point where I am, and they've asked us to talk about clinical applications, which I am all over, as we talked about in the first session. And one of the questions that's going to be asked of me later, I think, is what experience got me interested in craniofacial? And as it happened, when I was at the Mailman Center, we were walking by Jackson Memorial, and we were talking about cleft palate. We didn't see any cleft palate kids down there. We saw a lot of syndromes and other things. And one of the people that I was with said, don't even go into cleft. And we're walking by Jackson Memorial, and one of the premier plastic surgeons worked there. And it either would have been one of those things like working with Len Furlow. It's a treat that I got to work with him. And when I see him at a meeting, we talk about the old days. But I could have worked with this Bob Millard, or Ralph Millard rather, Ralph D. Millard. Or he was such an arrogant SOB, it would have turned me off from craniofacial completely, said I don't want to work with people like that, because there are some arrogant people. But I was interested in autism. Went from linguistics to autism. And I went to Florida because they had a great autism program, but I was going to figure out how the brain worked. We had a good autism program at South Florida. And I took the cleft course, finally, like the second year I was there, just because, and met Bill Williams, who turned out to be one of my best friends forever. And one day, it was like the first couple of weeks in the course, he said, who wants to come up and look? We've got a new cine radiography study that we're going to look at. Cine meaning it was film. There was no videotape in 71, 72. If there was, it was kind of reel-to-reel stuff. Radiography, and there was no good fluoroscopy back then. So when we did the studies, we actually had to take off the spot camera down in radiology at Shands, take off the spot camera and put on this huge, that had to be a 50-pound camera that we had to load 100-foot film canisters into first. And Bill projected the study on a wall, and I'm walking over here now, and I'm looking at all this stuff, and I see the teeth, I see the palate with the tongue and everything, and I'm going, this is even cooler than visible speech. This is really the speech mechanism moving. I said, by God, that's what I've got to do. I have got to do something where I can look at everything like this. I realize that I'm a concrete person. I like to be able to see something, touch it, measure it. And autism, I always felt like I was in this nebulae, and you're just trying to figure out in the brain what was working. And I hope you all, and now that you've kind of settled on speech, that there's going to be those aha moments as you see different kinds of disorders and say, this is so cool. I would work with this kind of population for nothing. Don't tell the employer that. And like me, you'll never work a day in your life. Every day will be a day at the beach. So what goes into it? This is what we kind of ended up talking about. Hypernasality is not a voice disorder. And this is part of the position statement that we wrote. Labeling a speech disorder should accurately reflect the anatomical nature of the disorder and avoid erroneous or ambiguous connotations. And it made so much sense to all of us. Try to get people on board I've just found impossible. So now I'm doing this again, 8 people at a time, appealing to your common sense, your knowledge of anatomy and physiology, that the velopharyngeal mechanism creates hypernasality, not the larynx. Why is all that important? Because it delays treatment. Like the 12-year-old girl, almost 12-year-old girl that I might have mentioned that had 22q deletion, 12 years of age. She's got pretty good speech now, but it's because we got trained clinicians that understood maladaptive hair, had all the tricks in how to work with maladaptive hairs. When I looked at all of our stuff at Duke, and then we kind of stratified everything by age, As you'll see, if we manage the VPI before 6 years of age, about 91% success rate, just right out of the box. If we didn't get them until 6 to 12 years of age, 74%. 12 to 18 years of age drops a little bit more, 70%. And then look what happens. You know, it is really a crapshoot as whether or not you're really going to be able to fix palate function. And a lot of that is motor planning. The brain has already been motor planned. And it's like you're trying to change an accent. It's like any of us try to learn a foreign language, we're always going to speak it with an American English accent. Which is, okay, it's better than having a cleft palate accent, which might be unintelligible. But this is something we highlight. This is the use of that research in a clinical. Why we really focus on getting these kids straightened out. And the kids that come to us with an open cleft, yeah, they've got 2 decades. They've got, I mean, estimates are anywhere from $100,000 to $300 in bills if the cleft goes through the lip and the palate. But they're with experts that are right there partnering with the family every day to make sure things go the way they should. This is the study that we're doing now. It's an R01 grant with the New York University, University of North Carolina, Lancaster, working with Rusty, who I was telling him his granddad was my first boss up there, Southern Illinois, and then Children's. And we're looking at these scales. Speech pathologists make a number of other ratings that we'll be able to compare across sites and stratify by. We haven't even started looking at different disorders, because we're taking kids that are going to have a pharyngoplasty and measuring them before, 1 year after, and then 2 years after. We're taking kids that have a bone graft, that have a mid-face advancement. So we haven't even started looking at all these speech measures based on the type of surgery that they had. But if we just looked at the just general, all these kids coming in, these kids rate their speech closer to what the nasometer rate their own nasality closer to the nasometer than to what the parents and I rate, which has just been simply eye-opening. We have 1,200 patients, and you can see the breakdown by gender. And we wanted them to be able to read, so we're seeing them at usually about 7 years of age. If kids are near that reading age and they need some help, we'll give them some help. It's translated into Spanish, so we're picking up primarily English-speaking and Spanish-speaking children. There's the average age, and they have to have some kind of cleft without a syndrome. So we wanted to leave that out because, as we know, everything goes down. Success just goes down when there's a syndrome. So we're looking at the second bullet point. I was more likely to rate the speech as normal than were the children. We're more likely to rate resonance as normal than were the children. We're likely to rate the child's intelligibility as more normal than the children. What is going on? You know, when you work with young kids, you just feel like there's something going on in there that they just can't verbalize to us yet. But give them a paper and pencil and take all the verbal consequences out of it, where it's just a graphic choice. You know, pick a number. You know, draw on the line where you think you are. I think we're going to get a lot more out of the kids, and it may change the way we do a lot of other testing of kids too, rather than ask them directly. Or maybe that's the next study we need to do. Here's a master's thesis. What would you get? And you could do randomized trial. Some kids would get verbal questioning first about skills, and some kids would get the written test first. And then you could swap. Half would go one way and half would go the other way. And look, does it make a difference in how they get the question? Is it a written question or is it a verbal question? That would be an interesting thing to do. That may be something that comes out of this. So as we said, the children and the caregivers, typically the parents, speech pathologists, we rate things in speech differently. children rate their speech as more different than others compared to the ratings by their parents. Children are more likely to characterize the speech as more hypernasal, less intelligible, and having a poorer quality than my rating. And you think, you have a couple of decades worth of training, and experience, you're pretty good at this, and then, a 7, 8-year-old kid comes along and says, no, it's a hot. It's a hot. And that's the other thing you learn, no matter how long you've been practicing, no matter what nice things the parents say about you, they've been told about you, they've read about you, that 3-year-old could care less. You're proving yourself he hasn't read any of the press clippings. You are proving yourself every 3, 4-year-old at a time. So we've got a lot more, and it's really getting me excited about looking all this data. We haven't had the second post-op studies done yet. That's where we're in the process. This is where we're having a database. We have our own database that I started 20 plus years ago when I started consulting at Children's that I can search. So we know when kids are coming back in, that I can't search from the hospital database. So it's the other thing is our database we use for the clinical information, clinical input of information, printing out reports. But remember we said every patient deserves good note-taking, very good record keeping. I've had this discussion with actually another speech pathologist at UNC, and we were doing an outcome study. We're trying to develop this whole outcome program. And she kept telling me that outcome studies, outcome research, outcome measures are different than clinical measures. And I said, no, they're not. You may recognize the name Michael Cornell. He's up at University of Iowa. He and I were on this panel group together. And I don't think that she understood where Michael and I were coming from. Our clinical information is going to be as exact and as clean as any research information as that kid will allow. It's hard to get good research information on a 4-year-old. It gets easy. We were always dealing with the age of compliance. But we can go back and look at our database because our clinical information, for the most part, with the exception of younger kids, is going to be as exact as any research data that we would be collecting. So short segment on some current research and the enthusiasm I have now for quality of life measures. And just the whole, we're already asking so many more questions. I don't know where we're going to get all the time and the resources to start answering these questions. But enough questions from me. Are there any questions from you?
Are you finding any cultural differences or similarities with the children that you're servicing?
We have not looked at that yet, but that's going to be a good question because in our English-speaking group, we're going to have probably a fairly large group of Caucasian kids. We're going to have a fairly large group of African-American kids, and I know we're going to have a good group of Spanish-speaking kids, Hispanic kids. So we'll see. But that's one of the ways that we're going to, that question's going in here so that we know that's how we're going to stratify things.
What are your thoughts concerning the resonance in children thinking that their resonance is so much different from others? If I'm thinking correctly, and what I've learned from audiology is we hear ourselves as being more resonant, our voices being deeper. So what are your thoughts on why these children are ranking their voices or voice quality so different or lower than your expectations?
That's a great question. It makes me want to sit down for a second. I've got a couple of thoughts about that. With those kids, I'm wondering if it's the kind of feedback they get from people. And I'm wondering if they're finding that their speech isn't intelligible. And that's the way they're responding. I also think, too, that there may be, it is true, when we're talking, we've got the air conduction, bone conduction thing going on. And we do see kids. In fact, I wrote about this back in '84, which was not a research paper, but it was a clinical paper, but is generally considered the reason why this happens. How many of you have ever seen kids that use posterior nasal fricatives? For S. What were you told? How does that happen? Because that's another way of just enhancing the nasal resonance. Why does that happen? Because second kid I ever saw as a student clinician at South Florida had that, and they said, this happens after adenoidectomies. And the thought process was there's a transient VPI. And okay, I didn't know any different, sounded good to me. But as I got more into it, especially as I got into resonance and cleft palate, and I realized, I was writing it was in one of the Harris Winnett's books, Articulation Disorders for Clinicians, by Clinicians. And I put forward my theory was, because these kids all had normal palates, that they had fluid. They had conductive hearing loss. And if you make us, how loud, any audiologists here? How loud is S? Go look at the Ling Banana, 20 dB, 20 dB. Yeah, 20 dB. So you can actually pass a screening, hearing screening, and not hear yourself say S. But if you swap roles with the tongue and the soft palate, and the tongue, instead of constricting the air, stops it, the palate, instead of stopping the air, constricts it, you're creating a lot of vibration right at the cervical spine, neck bone. And as we all know from anatomy, the neck bone's connected to head bone. And where's the ear bone? What's in the head bone? So you create this loud bone-conducted signal. So anytime I hear kids that are even more nasal, I'm wondering if they're not doing that for feedback, which is a kind of a long-winded way of saying, I appreciate what you're saying, and I know pretty much accept the fact, and I think generally in the clinical world, that's why kids come up with a posterior nasal fricative, is that they've got conductive hearing loss. When I hear kids that are a little bit more nasal, I wonder if they do that. We'll see kids that just vocalize with their mouth closed. And I'm thinking that they're doing that for the same reason. But is it something that has to do with, I don't know that we're going to have enough audiology. And as you know, the hearing level can just change on a day-by-day basis. So that part's going to be tricky to look at. But yes, it could be how they're hearing themselves.
Thank you.
Talking more about the study saying that the children are rating themselves closer to the nasometer than the speech pathologist and the parents are, what I'm thinking about that in terms of screenings. Like, let's say I'm working with an older population, not the little kiddos.
How old?
I don't know, school age.
School age, okay.
Or
Cooperative.
maybe preschool. Yeah.
Beyond the age of compliance.
Right. So I've done a few screenings, and in doing a screening, I never asked the child what he or she thought about his or her own resonance. What could be any implications of the understanding that the child's rating is closer than mine to what the nasometer says? What would be the implications of that for screenings that I do as a non-craniofacial specialist out in the world?
That's a great question. I think we need to figure out why we're getting this first. I'm not ready to say, it's just so interesting that we're finding this. I'm not sure what all this means. As she was pointing out, is it the way they hear themselves because they've got air conduction, bone conduction going on? I don't know. But that's another good question I'm just going to kind of tuck away. What are going to be the clinical implications? Right now it's just kind of we're to the point where, whoa, it's opened our eyes and said, we need to look at this more. This was an unexpected finding.
And the idea is that the nasometer is a more objective measure than maybe my ear.
Exactly. And I'll tell parents that a lot too, that the ear can be fooled, and we've known this for decades, that if there are articulation problems, that we will invariably rate hypernasality as worse. We will rate nasal resonance as more hypernasal if there's articulation problems. So we know that there's, but that's what I should have trained out of me. That I can look just at articulation, I can listen just for laryngeal voice function, I can listen just for resonance, and that may not be true. That may not be true. Any other questions? I will say this kind of flies in the face too of, what we generally have agreed on, again, for the past couple of decades, to get a good measure of velopharyngeal function, you need two measures. And most people agree one of them has to be your perceptual measures. And I've done other studies where we've compared my ratings to the nasometer, and they've been good. That's something we haven't done. So this is just kind of like the overall rating, but one-on-one, how does that rating for my rating of resonance for each subject compare to the nasometry rating right on down the line? So we still have a long way to go, but thank you. You've helped ask some more questions about these data. Thank you so much.